Okay, we have 10 minutes
Wait,
to go.
Okay, sure. Dr. Jasima, I can see you. Shakira, I can hear your voice very well.
Okay.
Yeah.
Alright, hold on a little bit. Just give me 1 minute.
All right, can. Yeah, Zainal also here.
Boleh dengar?
Cik Zainal? Yeah, hi.
Oh.
Can
Hi,
you hear
Cik
me?
Hi,
Zainal.
Dr.
Hi,
Jasima.
hi, hello.
Hi, hi, hi.
Assalamualaikum.
Salam.
Can you hear me or not? Can you
Yes,
hear me?
loud and clear. Loud and
Okay,
clear.
okay, that's good.
Alright, music can be here, yeah?
Yes, but reduce a bit lah. Too loud.
Just a little bit.
Shakira, if you can slow down the volume for a while, I would like to do a technical check. Shakira? Yeah. Can you go back to the previous slide? Yeah. Okay. Yeah. Can I ask our audience? I see comments that you're not able to listen to our audio and see the video. All good, Dr. Hitesh? Can you type in the chat? Is it okay? Are you able to see our audio and video? Okay. Yep. All right. I do see some comments here. All right. So I hope everyone can hear me. And we will be starting shortly. We just give another 1 more minute for the rest of our participants to join in. All right. Okay. All right. It's 2 p.m. Shakira, I think we can go now. Can go live?
Yeah, Doctor, we can.
All right.
All right.
Okay. Assalamualaikum and a very good afternoon and good day, everyone. I see our participants today comes from many countries. We're actually happy to see that. And we hope more will be joining in for our webinar session today. For Malaysia, it's a public holiday. For the rest of our participants and also colleagues from the other parts of the world, welcome to our webinar today titled Essential Industrial Hygiene Concepts for Occupational Health Doctors. And together with me, we have none other than Zainal Mubarik Zainuddin, a well-known industrial hygiene consultant from Malaysia, to deliver the presentation. It's going to be for an hour, and allow me to quickly introduce our distinguished speaker for the day, Encik Zainal. Encik Zainal, he holds a Bachelor of Science in Civil Engineering and Public Health from University of Newcastle upon Tyne, England, and also a postgraduate diploma in occupational health, occupational hygiene from Deakin University, Australia. He has extensive industrial experience serving ExxonMobil Malaysia, and after 25 years, he's currently the Regional Industrial Hygiene Advisor for the Asia Pacific. All right. And post-retirement, currently, he is working with Bureau Veritas Malaysia and Quest Petroleum and Shell Trading Malaysia, all in the role of consultancy. Encik Zainal is also one of the founding members and also the first president for Malaysian Industrial Hygiene Association from the years 2003 to 2011. And beginning 2014, he has actually chaired the MIHA Certified Professional Industrial Hygienist Certification Board competency training. Encik Zainal, I was told that this is one of the very tough examination from our industrial hygiene colleagues, and he has been doing it for the many years. And with 40 years of experience in the field of industrial hygiene, we are blessed today to have Encik Zainal with us to deliver the presentation. Allow me to convey some house rules before we start our webinar. All right, so I would like to kindly request all our participants, please keep your microphone muted to allow a smooth sharing by our distinguished speaker. Please stay focused during the session. And if you have any questions, use the chat box. We will be taking the questions later during the Q&A session. And please stay professional and respectful at all times. Whatever you're sharing in the chat column, keep it as non-confidential information and respectful to your respective organizations. And for your kind information, the session will be recorded and we will be making it available in our ACOH 2026 website. I will be sharing with you those details later. And for our Malaysian colleagues, please attend the full session to register for your MMA CPD points. We will show the QR code later. So thank you very much, and allow me to share quickly the agenda. Next one, please. So this is briefly, I'm your host for the day. I'm Dr. Jasima Begum binti Nazir Khan. I am currently one of the occupational health advisors with Petronas. I'll be your moderator for the session today. And following this, we will be having the actual sharing by Encik Zainal, followed with Q&A at approximately 2:40 p.m. And we will be ending the session with a quick promotion on ACOH 2026 and also how can you register for the MMA CPD points. All right, next. So without further ado, I would like to invite now Encik Zainal to proceed with his presentations. Over to you, Encik Zainal and Shakira. Encik Zainal, you can unmute. Yeah.
Okay. Can you all see my my pack now?
Yes, can.
Okay. Okay.
Yes, good.
Okay. Assalamualaikum. Good afternoon. Good day, everyone. Okay. First of all, I am very glad actually to be here today. Okay, to present a topic on essential industrial hygiene concept for occupational health doctors to you all. Now, I would like to thank the organizing committee of ACOH 2026 and also the Academy of Occupational and Environmental Medicine Malaysia, AOEMM, okay, for inviting me to present a topic in one of the series of webinars that you all are doing prior to the conference in 2026. So thank you again to the organizing committee and OEM. Again, I would like to say thank you to everyone for taking your time to listen to me today. Okay, and especially to the Malaysian, you are sacrificing your holiday time today, at least for 1 hour to listen. So hopefully we can have a very, I would say, beneficial discussion and sharing today. Hopefully, yeah. Now for the next half an hour or 35 minutes or so, what I would like to do is to basically share with you all some of those essential industrial hygiene concepts, okay, for the occupational health doctors. Now, I reckon this is a very important, if you ask me this personally, this is a very important, I would say, topic, especially for us in the OH, occupational health fraternities, because we need to basically work together. We complement each other because for us to be working or collaborating effectively, we need to understand each other's. So I think this is very, very timely and also very important topic. Okay. Okay, what I would do for the next half an hour, what I would do is to start with some kind of introduction, just to give, to set a scene, of why industrial hygiene concepts are pertinent for the occupational health doctors. So I'm trying to get, that's going to be under the introduction. Then I will go discussing some of those example of industrial hygiene concept. Okay. Now there are a lot of industrial hygiene concept. Industrial hygiene is a very huge subject, just like medicine. So what I would do is that I just pick and choose some of those. I would say consider to be very key industrial hygiene concept. Okay, that we can basically discuss today, and then I'll go through very quickly some of those resources for future learning for you all, for the OH doctors, and conclude with some key takeaways. Yeah. Okay. Now, first, let us understand why industrial hygiene matters to occupational health. I think that's a very important question that we need to ask. Why IH or industrial hygiene matters to occupational health? Yeah, I think the main reason is that because we actually are basically two sides of the same coin. Okay, industrial hygiene, occupational health doctors, as physicians, basically we are two sides of the same coin. We can be split. We can be split. Yeah, we complement each other. Okay, because the reason is that we share the same mission, we share the same goal of making sure that we identify, evaluate, and control workplace health hazard, so that eventually we can prevent people from being exposed and prevent people are getting getting work-related illnesses. So I think that's why I think it's very important that that we work together, we understand each other. Yeah. Now, for us to basically, I think in line with the title today, with the topic today, I think that's I think it's a starting point for us to bridge our expertise, to bridge our two expertise together, so that we can have a more, I would say, effective and safer workplace in the future. I think hopefully this discussion today, or this ongoing what I call it, discussion of understanding each other's area will be a good start for us to make for us to work closely, yeah, together. Okay, first let us go through the first, I would say, concepts or the fundamentals of industrial hygiene. The first one is foundational framework industrial hygiene itself. Anticipation, recognition, evaluation, and control. These are basically the first, I would say, the first concept I would like to bring up, because this is basically the foundation framework of industrial hygiene. And we strive to basically come up with a prevention strategy. All these are prevention strategies, just in line with the medicine's, medicine's preventive ethos. Basically, we're talking about making sure that people do, making sure we stop people from, from harm. Yeah, we stop people from being exposed, okay, or people being getting sick. I think that's basically the fundamentals, concept of anticipation, recognition, evaluation, and control. When we talk about anticipation here, we talk about right from the beginning, even before the hazards exist in the workplace. We have to make sure that we know, we anticipate it. Okay, we know, we anticipate it, so that we can prevent it from happening. Okay, for example, in industrial hygiene work, we talk about doing this during the design stage, even before, for example, the installation or the equipments come into the workplace. So we try to design, we try to eliminate the hazard right from the start. Okay, just like the doctors, when you're doing this, basically, for example, that you come up with some vaccination program, for example, so eliminate even before we know the risk. So before it happened, we anticipate it. Okay, so the same concept, yeah. Okay, and then in terms of recognition, in terms of recognition, basically we support. For example, for the hygienists, we will do an early detections of a hazard. So this can be done through assessment, either qualitatively or through quantitatively, with some measurement of that. So we detect the hazards early, so that we can come up with appropriate recommendation of control. Just like for the occupational health doctors, basically, by understanding, by recognizing the hazards that you have in the workplace, that we can basically, it supports early recognition. Okay, and you can correlate symptom or pattern, for example, respiratory, dermatological, or neurological with non-workplace exposure. So that's the reason why recognizing the hazards is very important. And then you can leverage case definition and symptom clusters to flag occupational etiologies. Interpret industrial hygiene data and air sampling, noise dosimetry, biological markers to quantify exposure, and order targeted clinical tests based on exposure metrics, and recommend hierarchy of control measures, engineering changes, and regulatory policies, and PPA evaluation. Now, for us, okay, even our age or occupational doctors, for us to do this, we need to be on the ground. We need to be on the ground, meaning that we have to understand. We have to understand the work processes. We have to understand the work environment. We have to understand the industry. So it's very important for RH or OH. I think this one I would say is the fundamental or the what do you call it? Important character that we should have. We should understand if you are basically consulting in an industry, you should understand the industry. You should understand what's going on in the industry, so that then we can basically what do you call it, go through all the systematic what do you call it, assessment of the workplace hazard. Okay, the next concept that I would like to talk is in terms of workplace hazard identification. Now, I think we're all aware that, I think you all are very, very familiar with. In occupational health, basically there are 5 major hazards that we look at. These are the 5 major hazards that we have. Basically, we talk about physical hazard, such as noise, vibration, either it is whole body vibration or hand-arm vibration, radiation, okay, either by ionizing radiation or non-ionizing radiation, lighting, heat, extreme cold, fibers, asbestos, dust, silica, mineral dust. These are examples of what we call it, physicals. Okay. Now, fibers, dust can also be considered to be chemical. Yeah. Now, biological, we talk about bacteria, insects, viruses. Okay. In real world, we talk about this come from food. Contaminated food consumption from virus, from bacteria and all that. So these are example of biological hazards in the workplace. Yeah? And then in terms of chemical, we have fume, gases, aerosols, mist, liquid, vapors from the chemicals that we use. So these are all the forms of chemical that usually you see in the workplace. Then in terms of ergonomic, we talk about manual handling, lifting, carrying, pushing, pulling. Yeah, and then repetitive movement, yeah, and especially, for example, working with the computer, a lot of repetitive movement, and then restrictive working area, which can cause awkward postures and all those things. So workspace is also very important. These are examples or things that we can find in the workplace. And then psychological or psychosocial, we talk about job stress, job monotony, unsociable hours, job organization, yeah, relationship with supervisors, job demand, and all those things. These are some of those factors that we have in terms of psychosocial. So these are the 5 major occupational hazards that we have in the workplace for us, industrial hygiene, occupational health, doctors. Yeah. Now the concept is that we as in the OH, RH, we should be able to recognize these hazards. Yeah, and the nature should be proactive. We don't let the things happen. We should detect it early. We should know it early. I think that's the concept. We don't want people to be exposed, okay, or have adverse effect only that we recognize this hazard. I think that's the reason why, for us, we should, as I said earlier in many of my, industrial hygiene is a practical profession. So I believe OH doctors also, OH physicians also a practical profession, meaning that you have to be on the ground. You have to understand, again, as I said, your work process, your industry, your work environment, for you to be able to carry out your job effectively. Because what I call it, so we need to be basically proactive. And how we do it, basically you have to be on the ground, you'd be at the site, you have to talk to the people, yeah. You have to basically understand the whole, what I call it, work process that you are serving, yeah. The reason is that now, in terms of what I call it, the usefulness of what I call it, getting to know or recognizing the hazards early, is that when you're doing your basically like clinical history taking, or when people comes and talk to you about some issues and workplace issues, then basically by having this understanding of the workplace hazard, then it will enhance your enhance your capability of mapping the occupation and the exposures. Yes. Yeah. And then it also help you to support, it also help support your what do you call it, your health and medical surveillance program. Yeah. Enhanced diagnostic accuracy, basically improve having understanding of the exposures in the workplace. It will basically you have a very what do you call it, you can correlate your passion, your worker symptom with likely workplace exposure. Now, if you don't know about some or other the hazard in the workplace, then it's kind of difficult for you to basically correlate that. So having that understanding is very important. It helps you to have a good diagnostic, what do you call it, capability. And then strengthen evidence-based recommendation. So whenever you make any recommendation, you know it. Okay, you know the place, you know the hazard, and I think it's much easier for you to come up with an evidence-based recommendation for controls. And then the next one is that it is basically very much at the end is that fosters multidisciplinary collaboration, meaning that when industrial hygienists, when the OH doctors, the safety officers, the management team understand the same workplace health hazard, understand the issues, then I think that the collaboration naturally will come in easy because we are on the same page in that. Okay, the next one is on now we already, so I'm going through like a very iterative or step by step. So we talk about the whole concept of anticipation, recognition, evaluation, and control. So I'm going through some of those fundamentals now, step by step. So we look at hazard identification just now. So the next one after we understand the hazard, so the next concept is exposure assessment and risk. This again is what hygienists is doing. When we talk about hygienists, industrial hygienists, we always talk about exposure assessment. That's our job. We assess exposure. Yeah, we assess exposure. And the reason why we assess exposure because we want to understand the risk. So the concept of evaluating either quantitatively or qualitatively the intensity. When we talk about exposure, we talk about intensity, the intensity of the hazardous substance, the intensity of the exposure, the frequency of the exposure, the duration of the exposure, and the routes of exposure to the hazard. So these are when we talk about exposure assessment, these are the things that we look at. Yeah. The reason is that this information, this exposure characterization is very important because only we can determine the health risk. Because if we know that, that the functions of health risk is basically exposure, okay, the exposure and the outcome, the health outcome, which is the health effects. So you know the exposure, you know the health effect, the potential health effect, then basically understand the actual risk. Yeah. So it's very useful. Exposure assessment is very useful because it allows for us, the RH and the OH, to estimate actual risk and make comparison with OEL, with the occupational exposure limit. Yeah. So it allows us to make that what do you call it, the comparison. Yeah. So we can place whether the risk is high, medium, or low by having understanding of the exposure. Yeah. And for OH doctors, basically it enable targeted health intervention. Yeah, because for example, like we are dealing with a chemical which basically, for example, like that people are being exposed at probably at a low levels, but over a long time. So then that's something that we need to look at. Yeah, so it enable us for a target health intervention. And then for you, this exposure assessment information is very useful because you can have informed differential diagnosis. So basically, you can distinguish between work-related and non-work-related. So we don't want attribution of what you call it, for example, not what related to the issues, to the symptom. So this information is very, very crucial. And also he guides on the biological monitoring as well. So for example, like that by understanding the routes of exposure to hazards, whether it's through dermal or through inhalation, or then basically it provides you some understanding of what sort of biological biomonitoring you're going to recommend. And then exposure assessment also will support in terms of your decision on fitness for duty and return to work evaluation. So when you have an exposure data, it will help the doctors to make a decision on whether these people are basically ready, okay, for continuing to do their job, if they are being overexposed, or if they are not, they are basically not fit for duty. So by having exposure data, you can make a good decision, or help you to make a decision where the people can be what do you call it, put place into work again or not. Yeah. Okay. Continuing on exposure assessment, there are a number of techniques in industrial hygiene, which I think would be good for you to understand. When we talk about exposure assessment technique, we talk about quantitative versus qualitative. Sorry about it. Yeah, it should be qualitative. So it's qualitative versus quantitative. Sorry about the spelling there. Now, when we talk about qualitative, we're talking about non-numerical evaluation of workplace hazard. So example of this is that the method could be like a walkthrough surveys, interviews, safety data sheets review, and all that. That's one way of doing this, non-numerical. It's very subjective, okay? The assessment can be done quite fast, and usually it doesn't cost that much, okay? It's good for screening and prioritizing for further assessment. Yeah, there are some formal, for example, there are some formal methodology already developed. For example, in Malaysia, the qualitative assessment is example like CHRA actually is a qualitative assessment. Yeah, chemical health risk assessment. And then for some of those chemical with a low toxicity, for example, they use CIRAC, simple risk assessment method. You also gain DOSH in Malaysia. Basically, this is one of the method what they call developed by DOSH. Okay, for example, in the UK, okay, COSH method, control banding. Yeah, this is one way. Basically, that is through the information that they have in the safety data sheet. So they use all those information for them to come up with some kind of qualitative assessment. Yeah. And then, okay, so again, the limitation, it is subjective, meaning that it is very much based, the quality or the accuracy of the assessment is very much based on the assessor's experience, knowledge, So people basically, it is kind of subjective and cannot provide exposure value because you don't have data. It is all what I call it, qualitative. That's the disadvantage of qualitative. Now, in terms of the other method we use is quantitative. Quantitative, basically numerical measurement of hazard exposure. We actually measure the hazards in the workplace. Now, the good thing about it, a lot of hazards in the workplace, especially the physical and the chemical hazards, they are quantifiable, meaning that we can measure them. For example, like noise can be measured, radiation can be measured, heat can be measured, hand-arm vibration can be measured, whole body vibration can be measured. So a lot of physical and chemicals, we can measure gas, we can measure vapors, we have ways of doing that, So that's a good thing. But there are also hazard that cannot be measured. Then that's where the subjective or the qualitative measurement, assessment come into place. So method again, these are thinking about air and noise sampling, biological monitoring, direct reading instrument for gas and vapors, and also for dust, for particulates. So we have those methods. The advantage is that it is objective, meaning that we have a value to compare. We can compare it with the occupational exposure limit. Yeah, and the limitation is required times, probably cost. Some of the equipments are quite costly. Okay, and we need equipment. Yeah, we need equipment. And the other limitation is that not, as I said, even though we have a lot of those can be measured, but there are some probably some of those, what do you call it, especially chemicals cannot be measured as well. Okay, the next one that I would like to basically have some discussion is on biological monitoring. This is another area where ACOH and OH doctors always have a discussion. And I think it's very important for you all to have some understanding of the concept of biological monitoring. Now, basically, we know that biological monitoring is basically measuring chemicals, okay, or substance or metabolites in a biological specimen. Yeah. Again, it's very useful, especially in terms of validating exposure levels and support diagnosis. Yeah. The good thing about biological monitoring is that it captures all exposure routes and individual variability. So some people, because when we're doing industrial hygiene measurement, we are doing it for representative, yeah. Okay, meaning that for some representative of the exposure group. But when we're doing biological monitoring, we're doing it individually. So meaning that if we take sample for 1 or 2 people in the similar exposure group, but when we found that the exposure level is elevated or more than the permissible exposure limit, then basically the whole group in that exposure limit needs to be going for biological monitoring, because we want to capture the individual variability. So we basically monitor individually. So that's the advantage of that. Yeah? Okay, enable early detection of exposure before clinical symptom. So basically, this again go back to the proactive. Yeah. So you're having biological monitoring, basically we can enable us to detect early of any changes for those people who are exposed to. And then the other one is verify and track effectiveness of control measures. Yeah. So if we come up with the control measures to protect people, one way to ensure that whether people are actually complying with all those recommendations or not is by doing a biological monitoring. Yeah. Now the limitation is that sometimes this biological monitoring requires invasive sampling, taking blood and all those things. And then the other one is that time. Time is very important in doing biological monitoring. Yeah, because of the half-life of the substance in the body. So we need to make sure that we really follow the timing, yeah, the timing of the sampling. So sometimes the logistics can, can basically interfere with having a sticking to the timing. Yeah? So so again, these are the limitations, the constraint that we have. And then limited validated biomarkers and biological limit values. Again, not many chemicals have biological exposure indices or biomarkers. And so it is very limited, not many chemicals have validated biomarkers and also BEI, yeah? Biological exposure limits. And then the other one is that there could be also issues in terms of interpreting things that come from a non-work exposure. Yeah, non-work exposure. So it's not easy to basically differentiate between work exposures and non-work exposure in the body, in the samples. Yeah. So that's one of the problems that we have in terms of interpreting biological monitoring data. It raises ethical consent and confidentiality consideration. That's another administrative thing that we have to deal when we're doing a biological monitoring. Okay, The next one that usually is important for the OH doctor to understand is this concept of occupational exposure limit. So occupational exposure limit, when we talk about occupational exposure limit, we talk about the maximum airborne concentrations of a hazardous substance or toxic substance to which worker can be exposed over a period of time without suffering or without adverse health effect. That's basically the general definition of occupational exposure limit. Yeah, and exposure limit can be basically regulatory and advisory exposure limit. So I think it's very important for us to understand this, distinguish between regulatory and advisory. Yeah, when we talk about regulatory, there's a lot of naming convention depending on the countries. For example, like PAL, permissible exposure limit, these are usually the terms used in the US OSHA, and also Malaysia. Yeah, and then WEL, work exposure limit, for example, is used in Singapore, okay, and United Kingdom, example. WES, work exposure standard, is this name OEL for standard in Australia. OEL, Korea and Japan, they use the occupational exposure limit itself for their limit, the exposure limit. MAK is German. So when you see all this, then you need to understand some of the terminology. And when you see this terminology, meaning that those are regulatory. There are also advisory limit. So advisory limit are usually developed by health NGOs, for example, like ACOH, ACGH, American Conference of Governmental Industrial Hygienists, and also by IHA, American Industrial Hygiene Association. For example, ACGH, they use TLV, threshold limit value. So whenever you see TLV, meaning that that's originated from ACGH. Yeah, so those are advisory. BI also come from biological exposure indices, also from ACGH. Yeah, and then REL come from NIOSH. These are basically recommended exposure limit. And what WEEL is work exposure exposure limit is developed by IHA, American Industrial Hygiene. There are not many WEL for this. Usually IHA will develop this exposure limit whenever there's no ACGH or OSHA limit. So normally they will come. So it's very, very limited. Yeah. Now, in terms of limit, when we talk about this regulatory and advisory exposure limit, usually there are three limits. One is TWA. So whenever you see any word that TWA, means that is the time-weighted average. Okay, time-weighted average is usually either by 8 hours. Okay, usually is 8 hours. When we talk about TWA, meaning that 8 hours a day, 40 hours a week. So it always relates to that time frame. Okay, and when we see STL, meaning it is the 50 minutes TWA, yeah, it is an average exposure over that 50 minutes. So that sometimes they call it STL 50 minutes TWA, yeah, and C is ceiling. Okay, so TWA is people, basically the limit that people should not be exposed to, because basically the limit that people allowable to be exposed to with, okay, for 8 hours a day, 40 hours a week, okay, without adverse health effect. Nearly all workers are basically do not exhibit adverse health effects. Okay, with that line. STL is basically the level, the threshold that we should not be allowing our workers to be exposed at any time of their working exposure during 50 minutes, 50 minutes TWA at any time of their working exposure. And C is a ceiling limit, the maximum allowable limit that we shouldn't we shouldn't be exposed people or workers at any time of their work exposure, at any time of the work exposure during the shift. Yeah? So these are the limit. So now, why these limits are useful? Because these limits are basically provide benchmark for interpreting exposure data. Yeah. it position OEL within the hierarchy of control, engineering, administrative, PPE. For example, that for people who are exposed to, for example, like TWA, 8 hours a day, I think we should be looking, because they are basically exposed to that exposure daily, every day. So basically, in terms of prioritizing the control, we should be looking for control which basically at a higher rank, for example, eliminate, remove, replacement, so it's more sustainable. Yeah, more sustainable. I think that's how we maybe say position OEL there within the hierarchy of control. And then the OEL also provide exposure level guide for medical surveillance. I think you are familiar with, for example, in Malaysia, we have that medical surveillance program protocol. So basically they use their PEL as a trigger level. So either use at PEL level for triggering medical surveillance, or they use at 50% LEL for medical surveillance. So it's used as a exposure level guides for medical surveillance program. And it support legal and ethical recommendation for workplace changes. Yeah. So that is the advantage or the what do you call it, benefit of having exposure limit. One thing I just want to caution is that never use exposure limit, occupational exposure limit as a fine line between safe and unsafe. So it is very important when we do our risk communication. So we shouldn't be giving the impression that it is safe or unsafe. Yeah. Whether people are being intoxicated because they're exposed to, being exposed over. So those are things that we as ACOH should be very, very careful. We shouldn't be putting that, because for carcinogen, we really, in terms of limit, it is very, very blurry. Yeah, it's very, very blurry. So again, it is very important for us to define that, not to give the impression that it is a fine line between safe and unsafe. Okay, hierarchy of control. Hierarchy control, basically we talk about this is a systematic way of ranking controls. Okay, controls. Okay, by ranking them through the most effective to the least effective. So they normally use the inverted pyramid to show this. Yeah, so it's very useful because this concept is very important. If you try to equate it with your medicine's what you call it, preventive ethos, you have tertiary, you have primary, secondary, tertiary. So you can consider like for primary, like elimination and substitution as a primary what you call it, control. Engineering, administrative as a secondary, and then PPE as a tertiary. That's how you can look at in terms of hierarchy control. Yeah, so it's very important. This concept is very important. It empowers the doctors. Okay, that because it drives prevention first. I think that is the main point. So for example, you can leverage the health surveillance trend to target hazard elimination of such. You can use that because if you have the surveillance data, you basically can push this kind of what you call it, recommendation. Align OH recommendation with workplace intervention. It strengthen control recommendation. Example, you can, for example, mapping specific clinical finding, early biomarker elevation for advocacy for engineering upgrade. So you can push that, through this. It enhance ACOH collaboration. So when we talk about same, common language for risk reduction and streamlining joint action. Okay, I think I'm running out of time, but I think I got a few more. Okay, resources. Okay, resources. I think I'm just giving some suggestion. There's a lot of books on industrial hygiene. Yeah, there's a lot of book. If you Google industrial hygiene book, there's a lot. The most popular three industrial hygienists are these practice industrial hygiene. But there are some basic industrial hygiene. For example, like fundamental industrial hygiene, you can, this National Institute Council's publish, what do you call it? So there is a lot of book you can. In terms of training, we have OTA training, occupational hygiene training modules. You can Google through OTA, what do you call it, website. There's a lot of training there, but one of the training that I would suggest is OTA 201, which is a basic principle of occupational hygiene, which is good for the doctors. Yeah, and then MIHA, Malaysian Industrial Hygiene, also have courses every year, so they also conduct some of these OTA training modules. And then IHA, they have a basic principle of occupational hygiene training. Is a 10 hours contact training. Is online. Yeah. So these are some of those resources that you can basically explore to understand more about industrial hygiene. Okay, key takeaways. Industrial hygiene is a foundational to workplace illness prevention. It is a diagnostic ally. Okay, we basically OHD and IH should work in synergy. Yeah. Then multidisciplinary collaboration to promote integrated prevention strategy for it. Basically, we need to promote this multidisciplinary collaboration. Yeah, to make sure that we have integrated prevention strategies. IH knowledge. Enhance clinical practice with workplace exposure science, enhance diagnostic accuracy through exposure awareness, and guides targeted prevention and intervention strategies. At the end, by complementing each other, we can have a holistic risk assessment and management, and eventually improve worker health outcome. I think that's probably my last slide. Thank you very much. So if you have any question, I think we can look at the chat. Yeah.
Thank you so much, Encik Zainal, for having this wonderful sharing with us today. It is actually an honor, if I can repeat that again, to have such an esteemed leader and experienced industrial hygiene consultant with us for the sharing. It is fundamental knowledge, but an extremely important knowledge for us occupational health practitioners. A good reminder, actually, how industrial hygiene and occupational health, we need to work together as a multidisciplinary approach in improving the workplace well-being. So without further delay, if I can take some questions in the chat here. First is from Cik Khairul Abidin Ghazali. Tuan, what's the difference between MEL and STEL? If I can have that first, Encik Zainal. Yeah.
Okay. I think these are just I would say semantic terminology. Yeah. STL is used by the ACOH, short-term exposure limit. Now, a lot of countries are using short-term exposure limit. As I said earlier, short-term exposure limit means that it's an average exposure for 50 minutes, time-weighted average. The average exposure over that 50 minutes that people should not be allowed to be exposed to. Yeah. But in Malaysia, it's kind of unique. Actually, okay, again, STL, normally not all chemicals have STL. Yeah. Because STL is based on health, some toxicological studies and all that. So they come up with. So a lot of many chemicals may have TWA and STL. Yeah. But there are also chemicals which don't have STL. Yeah. But in Malaysia, uniquely, don't ask me how it comes. The regulations come with what the term is MEL. Maximum exposure limit. The concept is very similar to STL. Actually, MEL is a 50 minutes average over 15 TWA. It is concept, except that in Malaysia, all the chemicals that you have in that schedule, in the schedule in the literature, they all have MEL. So meaning, they have basically the rationale. All those OEL, they just multiply by 3 times. And it become MEL, maximum exposure limit. Yeah, so I think the only probably country that have MEL for all the chemicals is Malaysia right now.
All right. So meaning that like for ACGIH or any other international bodies, they use either one, or how does it go by, Encik Zainal? If we can have more clarity, yeah.
It depends on so if, for example, if the chemical have both, yeah, if the chemical have both the TWA and the STL, okay, so you need to look at both. Okay, you need to assess both. Yeah, you need to assess both, meaning that first the priority is looking at the TWA over the day where the people are being exposed to. Yeah, so now if it is not, if people are being exposed to, meaning that you have something to basically work on. You need to make sure that people are not. But at the same time, there are tasks that could be exposing people to the hazardous substance. So so that's why hygienists normally they need to understand that. So if there are certain tasks occasionally done during the day that may, expose people, so then they need to also assess that. Yeah.
All
So
right,
that's
all right.
where STL comes in.
All right.
Yes.
Okay. Thank you, Encik Zainal, for that explanation on MEL and STEL. If I can go to the next question, it's from our Dr. Abu himself. The question is, with regard to the established OEL for similar hazards, why the different values were adopted by various countries, suggesting that some countries are seriously trying to protect their workers, whereas some others may not be? So that's the question from Dr. Abu.
Okay. Let me try to understand. Basically, why some countries have different.
And why some like perceived to be more serious?
Yeah.
Why some, they are not like having that
Okay.
certain type of benchmark? Yeah.
So if we understand the background of how PL or OEL for each countries, which is regulated OEL in the country, they don't just look at the health and the toxicology information. So that's why I said just now, if you look at NIOSH or what you call ACOH, they are very stringent. Yeah, they're very stringent because their limits are solely based on health evidence. Solely based on health evidence. But countries, when they adopt some of these, basically they factor in a lot of factors. For example, they factor in terms of practicality. They factor in terms of economic feasibility. Yeah, even politics. And that's why you see different countries have different regulatory exposure limit. Because there's a lot of other factors when they start to regulate, because they don't want to come up with a regular OEL that nobody can actually follow. Comply with. They don't, probably the infrastructure is not there. So that's the reason these are all the factors that they look at when they set up their own country limits.
Okay, I think this is also like one of the gap areas, even for Malaysia, academically or in the book. Some of the measures or recommendations how to do the biological monitoring or sampling has been there, but when we are looking for the logistic and the resources, the company or the service provider who may be able to do those kind of sampling and all may not be there. So there happens to be a mismatch in that, and I think the authorities are already addressing this gap. It's timely as well. And coming to that, Zainal, I have a personal question to ask, which is regarding our occupational health professionals. Sometimes when you talk about those based outside, not within the company, to get that resource materials, even to the basics of like CHRA or CSDS, how are we going to have the understanding about the hazard? That's the whole topic today about. We sometimes our colleagues face this kind of limitations. So what is your with your extensive experience, what's your advice on this? This is a real problem on the ground that is still going on. Yeah.
I mean, basically, when we talk about this, as I said, the ACOH or even OH, I think is a very practical profession. That's a key one. It's a very practical. If you are not on the ground, then it is going to be very difficult for you to perform your job.
Okay, so the key word is you have to be there on the ground to get things done. Yeah, right.
Understand. And as I think I keep mentioning, understand the work process, understand the work environment. If you don't have this, I think it's not easy to do it, because especially when you are consulting or when you are not working directly in the company, sometimes the accessibility is not there. But this is something that probably you need to work on. But I think being on the ground is the most critical, I would say, aspect of being a good ACOH doctors.
Practitioner. Yeah, I think this is also what many of our leaders keep emphasizing. You need to understand the science behind it, go to the ground, understand the entire process, so that you can come up with a professional judgment or input that you are providing to the workplace or the companies. All right, okay, the next one, I think also from Dr. Abu. Dr. Abu is actually a post Okay, maybe I can maybe take from Encik Helmi first. Thank you for such an insightful talk. What do you see as the most significant emerging hazard that industrial hygiene professionals should anticipate and prepare for over the next 5 to 10 years? I think Encik Helmi is asking about the emerging businesses and also what are the potential hazards. And additionally, there's another part to the question. Can AI and predictive analytics meaningfully enhance decision making in industrial hygiene? Yep.
Now, when it comes to emerging risks, I would say that one of the things that basically we are the way we work now, yeah, the way we work now is different from how we work in the past. Yeah, so the work environment is different. And I think we are still struggling to understand some of this emerging. Even, for example, working at home, example, yeah? We don't know right now, we don't know because we just started about 2-3 years back, since COVID, what, 5 years? Okay, we have not seen the impact of people working from home. There's a lot of, for example, ergonomic is one of them. Because if it's in the office, we can actually do, we have some control over people. We have some control over how people, but in the house, at home. So these are example of, I think, the challenge for the industrial hygienists. Yeah, the way we work now is different. We use a lot of the digitalization now, AI, you see, so we don't know what's going to be the new, what do you call it, new hazard that we're going to face. Yeah.
And to the second part of it, how are we already industrial hygiene? Are we already into AI, predictive modeling, and all that, Encik Zainal?
Okay, this I think we also discussed about this among our we hygienists, because now if you just ask question on hygiene, you will come up with all the answers already. Yeah, I think it's okay if you ask me. Personally, I would say it's okay to use AI capability, but I think you need to have the knowledge to distinguish between whether it's right or not. Because when you talk about AI, there's AI is not perfect. So I think you still have to have that, to make sure that I know that a consultant may just use use AI to come up with some recommendation, but you need to be very, 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 what do you call it, careful in terms of interpreting, making sure that it is the right one. So there could be some ethical issues there.
All right. Okay. Now AI comes with the small remark there. This particular AI portal or app can make mistakes. Please have that background knowledge or something.
Yes,
so it is not like, in my understanding, it's not complete. If you don't have the background knowledge or understanding, or you're not an expert in that area, then for you to proceed further, there may be some limitations in it.
Yes.
Right.
Yes.
And finally, Cik Zainal, Dr. Abu has a proposal here, an interesting proposal. It is important. IH is an industrial hygiene, is an important expertise for occupational health or occupational medicine practices. But to my knowledge, there's no formal training program provided by the tertiary institutions in Malaysia or Southeast Asia, either at the level of first degree or postgraduate. Can MIHA somehow initiate this, Cik Zainal? It's a proposal.
Okay, I take note of that. Okay, right now I'm not in the committee, so I can I think it's important. So I think we can bring that.
All right.
We can further escalate that idea.
All right. Okay. So in view of time, thank you very much, Encik Zainal, for the wonderful sharing. You have took us through a step-by-step guidance and knowledge sharing on the fundamental information for our occupational health experts over here. If I can just share a quick quote that I drafted earlier. Occupational health and industrial hygiene are not parallel paths, but intertwined phases. One safeguards the workers' well-being, the other shields against unseen hazards. Together, they create workplaces where people don't just survive, but thrive. So thank you once again, Cik Zainal, for being with us today, especially on a public holiday afternoon. And for the audience, do not leave yet. I have further sharing and a few other promotion to do. We have a few more minutes to go. Thanks once again, Cik Zainal. Now coming to our 24th Asian Congress on Occupational Health 2026, which will be held between 5th to 8th of August next year at Borneo Convention Center, Kuching, Sarawak. So don't forget to join us. Then you can start registering your interest at our website, www.acoh2026.com. If you can see at the below here, this is an example of our website and also the link for you to click. So if you can move to the next one, Sherry or Shakira. We have a video to share with you for the promotion.
On behalf of Sarawak government, I would like to support Academy of Occupational and Environmental Medicine Malaysia in bidding for 24th ASEAN Congress of Occupational Health 2026 in Kuching. Recently, I had the honor and the pleasure to announce that Sarawak won the bid for 24th ASEAN Congress of Occupational Health to be held in Kuching in August next year. This is the second time Malaysia ever hosts it, and the last one is 29 years ago. This is possible because of the collaboration between AOEMM, the Academy of Occupational and Environmental Medicines, as well as Business Events Sarawak to win the bid. I am so happy that my small short videos helped to win the bid. This conference will bring in more than 2,000 experts and professionals from the ASEAN regions. The economic impact of ACOH 2026 is valued at 16.4 million. Not surprising, because with 2,000 delegates, it will occupy more than 8,500 hotel rooms in Kuching. Currently, Sarawak attracts more than 45,000 conference delegates a year. About 60 to 70% of these conferences are medical. Conference tourism and medical tourism is emerging to be quite a substantial economic impact, not only for Kuching but for Miri and Sibu. If you like my updates, please follow my social medias and jangan tengok saja.
Yes, that was our Deputy Premier of Sarawak, Yang Berhormat Datuk Amal Dr. Sim Hui Kian, who was one of our strongest supporters and also promoters for ACO 2026. We really hope to see all of you there. I can see that our participants today, we have from India, we have from Indonesia, Thailand, and many other countries. So please join us. Please keep promoting the conference. This is truly, it's going to be an interesting cultural as well as a knowledge experience for all of us here in the occupational health and related fraternities. And in conjunction with ACOH 2026, we have been organizing a series of webinars. As you can see, we are at webinar series number 5 today. We have more coming up soon. A few others have been lined up until the end of this year, and also we will continue next year. So for the next one, as you can see here, we have one in October, another one coming up in November, December, and so on. In fact, in October, we're going to have 2. That's going to be very interesting. And you are going to get your MMA CPD points for each of these webinars for Malaysian participants. Next, please. All right. So again, if you have missed out on our previous webinars and you would like to learn more about these webinars, all you have to do is just Google ACOH 2026. It will directly bring you to our conference page. From here, if you can see the scroll going, you can see our past webinars. All the recordings are now available on our channel and also directly at this ACOH 2026 website. Okay, you can save the QR code over here. And next, please. All right, so this is just a quick promotion of the upcoming webinar. We are going to have one on disaster planning and response from the health manager of Shell International, all the way from, if I'm not mistaken, Netherlands, Dr. Halim Muhammad. He will be joining us on the 1st of October to share with us a very, very important and pertinent topic, disaster planning and response. So don't forget to join us. Quickly register at our website, www.acoh2026.com. Next, please. And this is the QR code. You can scan your interest for the either webinar or the whole conference, or in fact, if you're interested to be one of our exhibitors or sponsors, do reach out to us. You are more than welcome to join us to participate as the exhibitor or to sponsor for our conference. All right. So now allow me to share the MMA CPD point QR code. And we are having some issues. MMA scanner can't be used right now. So what you can do is please scan here, register for your MMA CPD points. What we will do, we will be submitting manually to MMA to get your CPD points in. So I will allow this